This video is a direct continuation of the video on NSTEMIs, so I suggest watching that video first and then watching this one, it'll make more sense. Okay, so a STEMI is ST elevation, okay? And these are usually worse than, well, pretty much are always worse than an NSTEMI. And that's because they affect more of the heart. They're usually due to a total occlusion of an artery, which means that even at rest, the artery can't supply this area the heart's demands for oxygen, which means that you get a massive area of ischemia that goes transmurally, okay, i.e. from wall to wall, okay, and this massive area of ischemia causes depolarization away from itself, okay, and because it's taken up an entire chunk of this wall, the depolarization is moving away. So if we have an overlying lead here, it's going to measure depolarization moving away from it. And as we know, depolarization moving away from a positive lead measures a negative value of voltage. Okay. Now, as a result, that lowers the baseline, because at rest, okay, at rest it is measuring a negative voltage, okay, voltage moving away from the lead. So instead of starting here, it starts down here, okay, so it does the opposite of a STEMI, because the ischemia causes depolarization to move away from the lead, which is going to cause a downstroke on a normal ECG if the depolarization moves away from the lead. Or in this case, it's going to cause the entire ECG tracing to move in the negative value direction. Okay, so if we change up this diagram here a little bit more for a STEMI, okay, this transmural area of ischemia is causing depolarization moving this way. Okay, so it's moving away from the lead. What it means, it starts down here, so we have our normal P wave and PR, okay, but it's in the negative direction, okay, so it's not gonna, so it looks normal on an ECG tracing, because the ECG tracings don't show 0 millivolts, okay, but it's going to be starting at a more negative value because of that initial depolarizing voltage moving away from the lead. And same with the just like with the NSTEMI, when the ventricle is completely depolarized and remains depolarized in the ST segment, that ischemic area can no longer depolarize the surrounding tissue because it's already depolarized. So what that means, the QRS complex returns, when it returns, the ST segment returns to 0 millivolts. Okay, because suddenly this area of ischemic tissue is no longer having its effect of lowering the baseline, because it can't do it anymore. The current can't, the depolarization can't move and cause depolarization in the surrounding tissue because it's already depolarized. Okay, and then once we have repolarization and back to our TP segment, this tissue again creates a depolarizing current moving away from the overlying lead, which again moves the baseline in the negative direction. So we have our T wave and it returns, oh gosh, let me draw that again. P wave, QRS, T wave is normal, and then it returns back to a more negative value, okay, because now this ischemic area here is able to cause depolarizing currents to move away from the overlying lead, and that's why you get ST elevation in a STEMI. Now, something I just want to point out, okay, if we look at, we'll just go to this area here as an example. An overlying lead here will pick up a STEMI, but an overlying lead here would pick up an NSTEMI because the depolarization is moving towards it. Okay, so it's not uncommon when you see someone who's having a STEMI to look at their ECG and see a STEMI in one or two leads, and then NSTEMIs in other leads. Okay, that's just something to be aware of. The reason that's important is because NSTEMIs can pop up even if the overlying lead, is overlying an area that isn't actually ischemic. Okay, it can be a residual change due to ischemia in another place. So if I draw a diagram here, if you remember in the NSTEMI video, I said that if you have ischemia here, it's going to be in all these directions. Okay, so lead here, here, and here would all pick up NSTEMIs. So what that basically means is that you can't localize the location of it, because a lead that's all the way up here is going to be supplied by a different artery. He's going to be looking at a part of the heart, that's supplied by a different artery, to a lead that's over here. Okay, sorry, a lead that's over here. So what that means is you can't localize NSTEMIs. Okay, which isn't too much of a problem because the treatment for NSTEMIs is medications. However, with a STEMI, although you get the residual changes if you have a lead here or here, although you get those NSTEMIs there, you only will see ST elevation in a lead overlying the ischemic area. So you can coordinate, you can work out which artery is affected by looking at where the STEMI actually is in terms of lead placement. That's important because with a STEMI, the usual treatment, as well as drugs, is to something called PCI, percutaneous coronary intervention, which basically means that you go in and pull the clot out or expand it with a stent. Okay, and the fact that you can localize it based off the ECG means that you know where it is, which will make your life a lot easier when you're trying to pull out or get rid of that clot. Okay, so that concludes STEMIs and NSTEMIs, possibly the series. If there are any other videos you do want me to do, leave a comment in the comment section below, and I'll get back to you, as well as any questions at all. And if you want to know about the ischemic changes that you see at a cellular level, I'll post a link to that video in the comment section below as well.